of time, we move on. So it's my pleasure to invite Dr. Lihteh to speak to us on subthreshold micropulse laser in central serous chorioretinopathy. Dr. Lihteh.
Thank you, Dr. Anand. Let me share my slides. So I'm going to be talking about our experience in Latin America regarding the yellow subthreshold laser versus PDT in eyes with chronic central serous chorioretinopathy. These are my disclosures. Note that I've been a consultant for Quantel Medical. And most of you already know that CSCR is characterized by choroidal hyperpermeability, pigment epithelial detachments, and retinal neurosensory detachments. In most patients, there's spontaneous resolution. However, in some patients, the disease becomes chronic with ensuing visual loss. So we decided to see what are the treatment possibilities in these eyes. And one of them is photodynamic therapy with verteporfin. So verteporfin PDT has been used to treat these eyes. However, PDT has some adverse effects that include a transient reduction of macular function, RPE atrophy, choroidal non-perfusion, and even the formation of secondary choroidal neovascularization. So in the hopes of doing that, some investigators try using either half-dose verteporfin or half fluence of laser light for the treatment of these eyes. And this is a paper that was published by our colleagues in Taiwan, and they used both PDT protocols, and they showed that these were effective in improving the best corrected visual acuity and eliminating subretinal fluid. However, despite these modifications to the PDT protocol, choroidal hyperperfusion still occurred. We in Latin America then decided to compare our experience regarding both PDT and the yellow subthreshold laser at 12 months of follow-up, because many years ago, about I'd say around 10 years ago, we did not have access to verteporfin. For some reason, the companies decided not to supply us with verteporfin anymore. So that's when we decided to do the switch about 10 years ago or so. So we looked at these sets of patients, and this was a retrospective comparative study of 92 eyes that were treated with either yellow subthreshold laser and 67 eyes that were treated with half-dose PDT. We define chronic CSCR as persistent subretinal fluid for 6 or more months. And these are the laser parameters that we use for the subthreshold laser. As already been mentioned, we use a duty cycle of 5%, a pulse duration of 200 milliseconds. And this is something very important. We did not have any spacing between burns. So this was indeed a high density treatment pattern. And the spot size varied from 100 to 200 microns. We did power titration as already described previously. And in our patients, the powers range anywhere from 320 milliwatts to 660 milliwatts. And so in our group, there were many who used the Quantel laser, but also there were also many that used the Iridex laser as well. So this was pretty much laser independent. With the PDT, this was the half-dose PDT. You're familiar with this, 3 milligrams per meter square of Visidyne, 15-minute infusion, laser activation for 83 seconds, and the spot sizes range anywhere from 400 to 2,000 microns in diameter. Can already show some of these results, but I'm going to go through them again in a little bit more detail. Here is a table where we look at the baseline characteristics. And basically what we wanted to show was that both populations of patients really were well balanced at the beginning. And you can see regarding age, duration of symptoms, the mean central macular thickness, subfoveal corneal thickness, and the visual acuity, they're pretty much well matched in both groups, so there were no differences. With regards to the 12-month results, you can see here the outcomes in both groups. So you can see here the subthreshold baseline and the results at 12 months, the PDT group at baseline and the PDT at 12 months. And you can see that there were statistically significant differences in both groups with regards to the central macular thickness, and the subfoveal corridor thickness was more pronounced effect with the PDT group compared to the threshold laser group. And the visual acuity, it was much improved in the yellow laser. However, in the PDT, there really not much difference in terms of the visual acuity between baseline and at 12 months. So if we look, dissect this a little bit more regarding the visual outcomes, you can see here that the gains and distributions of the visual acuities favored the laser, the yellow subthreshold laser compared to the PDT. We had more gainers, 3-line gainers in the yellow laser compared to the PDT. And the rest of, in terms of loss, it was pretty similar. Here's a curve showing that. You can see that the logmark curve with the PDT was pretty much flat. So the PDT was actually pretty good in maintaining visual acuity, but not too good in improving the visual acuity. In terms of the yellow laser, you can see that it was sustained, and actually after 3 months is when we started seeing some statistically significant differences in visual acuity, improvement with regards to the baseline, which meant it was maintained at until 12 months. These are the anatomic outcomes using the central macular thickness as a surrogate. We can see here that the PDT was able to drive more the fluid in these eyes than the subthreshold yellow laser. In terms of recurrences, we can see that with the yellow subthreshold laser, we had more recurrences, almost 25% compared to the PDT, which was 10%, with a mean range of 1.35 treatments, with a range of 1 to 4 treatments in the laser group, compared to 1.2 treatments with a range of 1 to 3 in the PDT group. However, these differences were not statistically significant. In terms of complications, with the yellow subthreshold laser group, we didn't find any. In the PDT group, one eye developed choroidal neovascularization, and this was treated with 3 intravitreal injections of bevacizumab. Let me show you a couple cases. This was an eye that underwent yellow subthreshold laser. You can see the ICG. Here are the areas of hyperpermeability, the OCT showing the subretinal fluid. Baseline visual acuity was 20/80. Following the laser, we can see that the visual acuity improved to 20/30. The subretinal fluid was gone. And this is an example of a patient that underwent half-dose PDT. You can see the fluorescein, the ICG, and the OCT with fluid. Patient had a visual acuity of 2200. And following the PDT, you can see that the fluid goes away, the vision improved from 2200 to 2070. So yes, the PDT also can improve the visual acuity in some eyes. It's also an effective way. And if you guys want to check out the details of the study, we published this at the BAJO a number of years ago. So how does our study compare with the rest of the literature? This was another study that was performed in Europe, and you can see that it was very similar to our study. 42 eyes treated with a yellow subthreshold laser, 58 eyes treated with half-dose PDT. And this group of colleagues from Europe also showed that the yellow subthreshold laser was more effective in eliciting a response than half-dose PDT. However, we have come across the PLACE trial, where it was a randomized clinical trial. And unfortunately, in my sense, this was not performed correctly. And I'll tell you my personal biases with this. So this study were 89 patients where you had half dose PDT compared to 90 patients with the micropulse laser. The micropulse laser was 810 with power type. They didn't do power titrations. They had fixed power settings, and you can see them listed here. And supposedly they said this was high density, but and then they showed that the high dose PDT, half dose PDT was superior to the micropulse laser, both in functional improvement and complete resolution of subretinal fluid. So based on this trial, they just buried completely subthreshold laser, at least in central serous chorioretinopathy. But again, we have to look at the details. And they said in their paper that this was supposedly high density. We sent the letter to them, and they told us that the laser spots were positioned adjacent to each other in a non-overlapping fashion. However, they did not use a multi-spot pattern scan. And that is a problem, because if you realize all these burns are invisible, and if you do not have a pattern, how can you really be sure that your burns are next to each other without leaving any open spots? So this is a major problem that I think really influences the effects. So my feeling is that in the micropulse laser arm of the PLACE study, the eyes were undertreated. So in conclusion, both half-dose PDT and the yellow subthreshold laser are effective in restoring the macular anatomy in eyes with chronic CSCR. However, it appears that yellow micropulse laser has a more beneficial effect in visual acuity than half-dose PDT. Thank you very much for your attention.
Excellent presentation, Lihteh. Very nice.
Thank you, Jay.
Great. So we have a couple of questions from audience. Let's start with them. We have a question from Dr. Mazumdar from Delhi. Her question is, should the amount of retinal edema not be factored in the titration? Do you have any comments on that?
Well, you know, I think in your guidelines paper, we said don't bother with the amount of edema, because, you know, I think the target is the RPE. And since this is going straight, if you focus correctly, it shouldn't really matter. Yeah.
Okay. Yeah, that is true. That is true. And considering the nature of the subthreshold, we really do not want the adjacent temperature to be raised. That's why we really don't care about the amount of edema there. So the next question is from Dr. Aditya Verma, that can you please explain the reason why should there be no spacing between laser burns? Does it decreases the efficacy of laser?
Yeah, so we are extrapolating really from a paper that was done by our colleagues in Brazil, where they looked at eyes with DME. This paper was published in IOVS, maybe 2014, 15, around that time. And they actually looked at 3 different groups. One group was a conventional ETDRS macular grid or modified grid. And then the other one was micropulse with high density, and the other one was micropulse with not high density. And when you compare those 3, both the anatomic and the functional results were much better in the arm that had high density. So you know, that's how I feel that maybe, you know, you really need to treat the whole area, and when you're not really treating the whole area, then you run the risk of undertreatment.
Yeah, true.
I just had a question. When there are areas of, you know, EED, RP, atrophy, fibrin, would you modify your grid or skip around it when you address this, you know, to avoid any kind of complications, do you think?
No, I don't. I feel like since this is really subthreshold treatment, it shouldn't really matter.
Yes.
Yeah, true.
I think Rohan had a question.
Yeah, Rohan.
Thank you. So I just wanted to ask, in suppose of case of fresh CSE, you have a clear-cut single burn, a single leak, and you have decided on your laser settings. So when you hit on the leak, do you just give one spot or do you repeat it 3-4 times with the same setting?
Well, I mean, if it's just a single leak, I think you can treat it many different ways. So, if you want to treat it, if it's subthreshold, I don't think it really matters. If you are going to do regular laser, which is an option if the leak is really far from the center of the fovea, then probably I would just do one direct shot there. But for acute things, and I just use the same. I don't modify the settings.
Okay.
And then I think that's the benefit of doing subthreshold laser, because so you can actually do a little bit few more spots around that area, because it's not going to cause any scarring. Yeah, Dr. Giridhar?
Yeah, I mean, a nice presentation. I had a few questions to. One is, in one of the indications for micropulse as far as CSR is concerned is one is subfoveal leak. I mean, are the parameters the same as what you do outside the fovea, or do you have a different parameter when it comes to a subfoveal lesion? Number one. Number two is in chronic CSCR, where you don't have any focal leakage in your fluorescein angiogram, do you advise ICGA to identify areas of leakage and treat them with the subthreshold laser? Because that's what I do in some of these patients, where I identify the areas of leakage in ICGA in midface and treat those areas with a subthreshold laser. Because otherwise, we really do not know where exactly to treat.
Yeah, so regarding the foveal leak, I do not modify. I mean, I think what Jay said is very important. Before pressing the pedal, you just have to make sure that your parameters are correct and that you are indeed in the micropulse or subthreshold mode prior to doing that. Otherwise, you might cause some problems. With regards to using ICGA, yes, I use ICGA in a lot of these eyes. The problem is that ICGA is not widely available. That's why, I guess in the guidelines, Jay didn't mention it, but ideally, I think ICGA is superior than fluorescein in terms of determining the zones of hyperpermeability.
Thank you.
Okay, you had a last comment.
Dr. Ajay, you have any question?
Victor wants to give a comment. Victor?
Yeah, so I think that I want to comment a few things on the past few questions. I think the titration is important, that you need to kind of learn that in the beginning. I think that Jay mentioned that already, but I think I want to reinforce that you want to be powerful enough that you have effect, and then also not powerful enough to see any scar afterwards. So I think the initial, when you're first starting, that's quite important to titrate that. Because I think that we talk about cutting down by 50%. So if you actually wait until to see a very clear, visible burn, you might want to cut it down more. I think some of our colleagues that want to be more confident to see the burn, and then they cut it down to 1/3. And again, the original 50% is partly that I think that it's easy for me to divide the power by half than by 1/3. So I think those are something that you might want to audit your initial result when you first start doing them. And then secondly, that once you have, and also to reinforce that the test burn are out in the outside the edema area. So I don't know whether that question was whether edema matter or not. So because you're not testing in the edema area, because I think that's also important. And again, just like Jay and Lihteh already mentioned, that on your first burn, so to speak, or probably first spot might be a better word, that you might be just want to make sure that is, when you turn it down to 50%, you are become not visible anymore before you start treating. So there are all these kind of things that you don't tend to do it anymore when you're very experienced. But in the beginning, I think those are good practice. And similarly, don't touch the fovea in the very beginning. But I think once you get your titration sorted out, you know what you're doing, then I think then it's quite safe to do so. And similarly to the question about whether you want spot or few spot for CSR, and indeed that I tend to treat a little bit bigger area than the lead gauge for CSR. And again, that's controversial. Not everyone agree with it. I'm happy to treat a little bit more, seems to give a slightly better result. And indeed, when we publish a paper that if you do that a little bit extra, seem to have slightly better result. Not that scientific, to become a more personal preference. And again, also go back to the question about you can't really get a dead cell when some of the area they already got RPE atrophy. Those are dead cell, and you can't really make the dead cell to be stimulated. So I think sometimes that you treat a little bit beyond, although you might be normal retina, but again that might also help to inducing the response that we want to see. And finally, the question about overlapping, I think that is really, certainly when I was training fellow, one of the common mistakes is people tend to undertreat because they come with a history of treating with conventional laser. As Ken mentioned earlier, that in conventional laser, you had the scar, which is a dead zone, and then you had the ring around it, which is a subthreshold zone. That was a biological effect. And so you do need to have spacing, because if you don't have spacing with conventional laser, you basically kill all the retina. And that's actually how the concept worked without thinking about it way back in the years. But obviously with subthreshold laser, you don't need to do so. And you can put it next to each other. And then we're kind of combining the biological understanding as well as the clinical data Lihteh mentioned earlier. That's why that we're actually suggesting very, very close by, and it's easier to do that with pattern laser for that matter. And then finally, the way back in the days that we actually have deliberately hit a same area 3 times to see whether that you can actually see a spot, and appears to be that you can get it up to 3 times, you still get away with it. So I think that there's also in the beginning, a lot of colleagues are worried about a little bit of overlapping. And I was suggesting a little bit of overlapping is not a problem once you actually have get the titration right and also audit your result. And if you actually have too much overlapping, then you will see scarring as well. Then obviously that was not right. So I think the reason that micropulse or subthreshold laser are not get adapted to, because you need to change your behavior a little bit. I think that just same thing that when many of us are changing from extra cap to phaco, I think that we do think quite differently. And I think the new generation just learning from phaco from the start actually easier. And in fact, there's people who never done laser before, find doing subthreshold laser much easier. And Ken mentioned that about the diamond study. We're actually trying. The paper should come out very soon. I think you get accepted. And we're actually planning to changing very inexperienced people to do this methodology. So it's a little bit of training, but I think once you know how to do it, it's actually much easier than even conventional laser.
Thanks, Dr.